Oh, thank you very much, Dr. Moore. It's Michael from Waterloo Region. That was fascinating. What I can't see on my side, Christine and Kim, is are any questions that might pop up. Um, so I leave the questions to you. Quick
Okay,
question.
Ada does have a question. I'll open the mic to her whenever you're ready. Go ahead, Ada.
Hello? Hi. Thank you very much for the presentation, Dr. Moore. I have a question regarding the opioid risk tool, I guess is what you refer to it as. I know that doctors have been using some sort of questionnaires with their patients for a very long time. So I believe these tools are not really that effective. And I don't think they're even validated in any really scientific way. So I'm a bit concerned that I would prefer to see a physician inform the patient with informed consent, with clarity that I'm going to prescribe you an opioid, and this opioid is a narcotic, excuse me, and you know, this is what can happen with the opioid. Rather than using an opioid risk tool, which to me is like watching the commercial on TV where the, hello?
Go ahead. We're just
Showing, sorry, there's an echo coming back. But anyway, it's like watching TV and they're advertising a colonoscopy. If we were through, we wouldn't need a colonoscopy. How can a doctor make a determination based on an opioid risk tool or a questionnaire? If I come in to see a doctor and I'm in pain and the doctor says to me, fill this questionnaire out, and I end up that I'm at low risk for addiction, it doesn't mean that I won't become addicted. And by the time the doctor figures out that, you know, the patient may become addicted or shows signs of addiction, that's too late. So I would like to see a different approach where the doctor clearly informs the patient and then do not provide an opioid unless it's medically appropriate. In other words, not for low back pain, not for mental disease or mental health. There's so much in the way of data that we now have and studies that show opioids shouldn't be used for chronic non-cancer pain for long term. And the medical studies haven't been done. So why aren't we preventing new starts on opioids? And we should be treating those that already have the disease of addiction. These opioid risk managers and tools, to me, just stigmatize the patients more and present a false dichotomy that there are groups of people that you can give these drugs to for a long time and nothing happens, it's safe, it's effective, and then you have the abusers and that's why they become addicted. And we know there's a huge overlap and there's a lot of pain patients that are addicted. Sorry.
Well, no, I understand completely your sentiment, and I think these tools are evidence-based. If you go to the opioid manager, and look at the first question is, are opioids indicated for this pain condition? And the second question is, have you explained the potential benefits? The third is, have you discussed potential adverse events? Have you discussed the risks? Was patient given information sheet? Did you sign the treatment agreement? Have you signed over about potential urine drug screening? And has ongoing systematic management if you can prescribe a narcotic? And the screening tools are evidence-based and come from the National Pain Center at the Master. So most of these screening tools are good, and they're meant to decrease prescribing. They're not a risk management tool. They're to stop the initiation of the narcotic. If you have a high addiction score, or you have a high opioid risk score. They do have good evidence behind them. And I agree with you. Initiation is what we have to decrease.
Okay.
There's some presenters, there's some evidence to suggest that this government review that I mentioned earlier, that chronic non-cancer pain was a diagnosis created by and organized with pharmaceutical companies.
Right. Right. Okay. Thank you.
But I'm right with you. Stop initiation, and if you do choose to prescribe, please do so safely in an ongoing systematic basis, which that opioid manager incorporates.
Okay, thank you. Are there any other questions? I'm not seeing anything coming up. Luba has a question. Go ahead, Luba.
I have a question regarding the Ontario monitoring system. Why does it follow the ODB system versus the Federal Narcotic Act?
Can you explain that a little more?
Can you repeat that, Dr. Moore? Dr. Moore, we're not hearing you.
Oh, I just have one question. The details of the drug aren't out yet. And it's a provincial drug monitoring system. It's monitoring prescribing by Ontario physicians for narcotics and controlled drugs. And it is to allow improved safety, to decrease levels offering, and to monitor prescribing habits across the province. That's my understanding. What we haven't done is incorporating through a negotiated pathway how the data will be used to improve prescribing among physicians and to educate those physicians whose practices are perhaps outside the norm.
Okay, I think Michael has a question, and so does Kim.
Thanks, Christine. Thank you, Dr. Moore. Just the last question makes me wonder if we were to ask Health Canada, how many people overdosed and died, or overdosed and were injured in any area across Canada. I really wonder if they'd be able to offer up any kind of answer. So I know there's interest in other provinces around monitoring. Is there a possibility, are you aware of other provinces that are already using like an ACES system? And is there a possibility for integrating across provinces, coast to coast to coast, so that we can get a more of a Canada-wide snapshot? And yeah.
Yeah, well, great question. Thank you very much. There is potential to, what I would do is get sentinel sites across the province. So hit your bigger cities and get a sample of smaller emergency departments and link them up. Once the system's in place, there's not a lot of extra investment to monitor extra hospitals onto the system. And I think that would be a worthwhile endeavor. There are other provinces that have drug monitoring systems, and I think Alberta is a leader in this field. And I think it would be great to have someone from that province speak on how they utilize the drug monitoring system for prescribing, whether they've had similar problems to what we've had in Ontario.
Well, thank you very much. And something else in your presentation, just around, I think you had indicated about getting, kind of information at through harm reduction programs delivered by public health units, and of course there'd be other harm reduction programs as well. But just for the folks on the line, one community in Ontario has used the Crime Stoppers line for people who are using drugs or agency people who are running into it. They've used the Crime Stoppers line to report adverse events and the presence of bad drugs in community. I thought that was a rather novel and ingenious way to let folks know, and it might trigger something at the local public health unit. But of course, Crime Stoppers is completely anonymous, so just had to mention that.
Yeah, very good. I think along that line, our methadone clinic monitors for contaminants like levamisole, which have been used or introduced in cocaine, and it can cause significant harm to individuals if they get high enough dose of levamisole. In particular, it suppresses your white cells, make you start spontaneously bleeding and/or get life-threatening infections. And they inform us if they get urine samples of having any levamisole, so we can inform the emerging and the drug-using community that some of their drugs are tainted. So I think these local feedback and communication strategies are excellent opportunities.
Great. I've got two more questions. One's from Liz. Issues around acute pain situations, dose and duration are often more than required. Is there a move to educate and thus prevent excess medications that are available for diversion?
Say it once more. Moves to.
Is there a move to educate and thus prevent excess medications that are available for diversion?
Yeah. The main way I see that we monitor diversion within our practices is that we have the patient contract, we have appropriate screening tools, and we use urine screening to ensure if we prescribe it, the patient in front of us is the one that's actively taking the medication. If we screen, if they don't have that drug that we prescribe in their urine, there must be either not taking it or they're diverting it. So we have to have an honest, straightforward conversation with our patients. And I think we can apply that systematically for every person that's prescribed and not stigmatize it. Okay? This is just a rule of practice. For safety, we can ensure that our prescriptions, which is 37% of the market in the LA area, aren't getting diverted. We've been encouraging that on a practice level within our community, since we have one of the highest prescribing rates.
Great. And then Jane has a question or comment. Could you comment on the potential for overall surveillance to incorporate cocaine, heroin, street use of Wellbutrin? There are monitoring systems elsewhere looking only club drugs, new psychoactives, etc. Just wondering.
Yeah, I think the only way, just by getting someone's diagnosis in the hospital, we probably aren't going to be able to get changes in local drug habits. We really do need the urine tox screening. So any patient that shows up with overdose, as emergency, we can't explain their behaviors. We often send urine off for tox. But that information doesn't get to decision makers, it doesn't get to public health. We don't get informed of any baseline changes. And I think that's rich information. It doesn't have to be identifiable at all. We just need to know 21-year-old showing up with Wellbutrin in the urine and or a new drug abuse, and they have these signs and symptoms. We can educate. If we got that information, let's say weekly, we could educate and send that information back to all prescribers in our community to improve safety. And that's why I think Sentinel, your emergency departments that provide their local health unit or their family health teams with current changes in drugs abuse could be quite helpful for prevention strategies.
That's wonderful. I don't have any other questions.
Okay. Well, we're almost at our time.
All right, thanks.
Go ahead, Kim.
Thank you. Thanks, Dr. Moore. That was fascinating to see what could be and what elements should be considered and what's happening. And I really liked how Michael was asking some questions about, could this be pulled together nationally and what might that look like? So a couple things, yes. I would like everybody to know that there's a terrific film online, Eyes Wide Open, the film, 7 minutes long, and with lots of great food for thought and very inspiring. So have a look. It's available online at preventingcrime.ca. And we may need to reschedule one of the webinars that was canceled earlier. Hopefully we'll have the opportunity to hear from Dr. Urfandala at a upcoming time yet to be confirmed. But at this time, I think we're sadly ending our webinar series. But the good news, of course, is that all the webinars either are readily available right now online at preventingcrime.ca. Their link is there, and the ones that are recorded today will be up very shortly. So we're really excited that they're going to be there for even more people to view and for you to share. Clearly, one thing I've learned throughout this whole webinar series is that A, there's much to know, B, there's much more information that's just emerging that we need to follow up on, and C, so many more people need to be made aware of what's going on and to hear the different ways that people are framing the issue. It's been fascinating to hear from experts across the country and in the States and abroad on their perspective. It's just been a huge eye-opener, if I can use that word. So, Dr. Moore, thank you for bringing your particular expertise to the discussion today. It's been fascinating, and we wish you all the very best at having these ideas move forward and implemented, and we certainly hope that other medical officers of health, both in Ontario and across Canada, will join you in seeing the validity and usefulness of this. And we certainly appreciate taking time today out of your very busy schedule to share what you know and to leading the charge on this. So, any suggestions for other topics? If you have some, please email us and let us know. You can reach us at Eyes Wide Open, WRCPC, that's short for Wilder Region Crime Prevention Council, at gmail.com. And Michael, are there any last words that you'd like to add before we sign off today?
Well, I deep debt of gratitude to Dr. Kieran Moore for sure for all the work to date and the work to come into the future for non-medical people and community. This is really essential stuff. People at the sort of street level feel it first, and it would be great if the monitoring systems pick that up in real time. So much gratitude to Dr. Moore and Kim. Thank you for your the overview of the series. We're quite proud of it. Dr. Dahlia, who was scheduled for in March, went off and had a baby, came a little early, and we'll reschedule him, so pay attention to the website, check in every now and then, but I would expect that would be later in May when he returns to work at St. Mike's. So on behalf of Kim and Christine and myself, thank you, Dr. Moore. Thank you to all who are chipping in and doing what you can to resolve what is quite clearly an opioid crisis. Bon voyage.
Thanks, everyone. Have a great afternoon.
You too.
Bye-bye.